So we discussed previously what we do up to now, what we feel confident, and what is our dream. I'm a dreamer, so I thought that I was a little bit not sure about CBCT now. I will show you that I'm thrilled with the CBCT. And speaking the truth, is the HDVI that's different from CBCT, as I told you, that I try to distinguish all the other machines that I don't know. So I know Vimago, and this is my experience. So we feel comfortable doing myelocity. We are sure that if you want to evaluate the carpi or the tarsi, you need a Vimago image rather than a CT. And I'm speaking also with a comparison with a 128 slice CT. So in most of the cases I push the Vimago to compare with a high technology CT, in which there are physical limitations for the CT. So if you have like a small structure like the carpi of a dog, or medium or a small breed dog, it's worse. In our reports, it's not diagnostic imaging, it's diagnostic imagination if you don't have a cone beam image. Arthrography of the stifle. I'm a fan of it because it's easy, fast, and we feel comfortable. We can see, like, with all the movements, we can see the meniscal tear if there is present. And in most of the cases, yeah, the gold standard is also the arthroscopy. But it's important to know if you do the arthrotomy. A lot of colleagues, unfortunately, in Greece or in Cyprus, they do arthrotomy a priori. But I said, why? Why? Because they don't feel sure. So if they feel comfortable that the radiologist says there's nothing in the meniscus, don't go. Clinical science doesn't, they're not worried, so they don't go. So that's something we like. Elbow dysplasia. What is happening up to now, that all the credits that they're getting for the breed accreditation, they do radiology. That for me is something insane, that 2025 we're doing radiographs for the elbow. But why that's happening? Because we don't have a standard image protocol and quality with the CT. So many of the colleagues say, let's put the one forelimb inside the gantry, take out the head, or in supine or in prone. They try to discuss, but the main issue is that what we miss with the CT is small lesions. As Professor Martini, we do care about minor findings, not the major. The major findings you could see on an X-ray. But we are here to improve our skills, to improve the offer to the vets and to the pets. So we are going to say how we can push a CT to see a non-displaced fracture of the medial coronary process. It's way difficult. So sometimes you can imagine a fissure line, you stress your iterative reconstruction, but there's a limitation. So you say, go to arthroscopy. And the arthroscopy says, yeah, but if I see the subchondral and I don't see the fissure that's underneath, what we can do. That's why now I'm sure that in the future, when we fix our protocols, I think the HDVI for the elbow dysplasia will be the best tool to evaluate. The total body protocols are protocols that we have to. The difficult part, also for anesthesia, also for us, is we cannot do the protocols as they do in human medicine. Because in human medicine, they want a specific part of the body to examine, and we have the same morphology, more or less. It depends also from the kilos, but the dimensions are more or less the same. So you put the age, and you have your protocol. While for us, it's like we have patients from 50 grams, 1 kilo, 3 kilo, 60 kilos. And the question is not always the same. It's not always clear. If you have oncology patients, what you have to do. It's way difficult for us to write down protocols, fixed protocols. I modify the protocols every day, depending what we are searching for and what we're going to do. The major thing that I tell to all my colleagues is when you do an oncology patient and you have a lesion, should inject the contrast medium for the post-contrast studies. Where is the area of interest? And don't pay attention that much, for example, for the metastasis in the thorax, because I can see it in the native images. So I don't care about the contrast in the thorax if you have like a lesion in the head or in the abdomen. While if you want to see some lesions of the thoracic body wall, then you do the contrast there and you can combine it with the abdomen and do the delayed phase for the brain. The acoustic canals, what we are now going to do is if we can depict the membrane if it's intact or not. It's demonstrated that in CT we can miss the membrane. So it's something we should post the Vimago and publish that we can see it and we could be sure. The brain studies, our future research will be in the perfusion. So as you know, with a classical CT, we can do the perfusion study in order to see like an ischemic brain disease. That was something or in the MRI, we do the TOF sequences to see the vessels. So we will try to push and to see if we have any ischemia and we can depict it. We can depict easily the high vascularized lesion, as you saw previously. I showed you like the choroid plexus tumor, meningioma. It's easy. But what's happening with a glioma? Also in CT, you don't see anything. So I had cases that I could depict like the hypoattenuating area and the mass effect. So what you can see with a glioma is that you will see the mass effect. That's very important, that the Imago, I can see the falx cerebri and I can see if there's any displacement. So I say, okay, there's something there. I'm pretty sure that this could be like a neuroepithelial tumor because it doesn't enhance. So if you want to be 100% sure, go to MRI. And MRI, what does it say? Yeah, you have something there, but it doesn't enhance. So do you have the biopsy? No. And this is how our scientific approach is getting further. So our first goal was to see if there is something there. And many years ago, the vet says, if there is a tumor, there is a mass, we don't do nothing, we do euthanasia. That was our approach as a vets. And now what we say, there is a tumor, we can do surgery, we can do laparoscopic surgery, we propose something. What's happening for the brain other than the CSF tap? We don't propose anything. We say there is something there. If you don't have radiotherapy close, what do you do? This is something that we should take care of. We can find criteria to prioritize a round cell tumor rather than a meningioma. And if you say, like, I can see that's a meningioma, so you can go to surgery. But if it could be a round cell, yeah, I'm not sure. It could be a glioma. Yeah, I'm not sure. It could be an abscess. Yeah, we have some criteria in MRI, but we're never sure. So we'll discuss what we will do in the future. Cardiac studies protocol. So I have a 128 slice ECG-gated CT scan that is easy to do cardiac studies, and then you should try to have like 60 to 80 beats per minute, or if you go over 100, you know the quality there, we're not so sure. And with a previous generation 16 slice CT, could you do a cardiac study? Yeah. It depends from the anesthesia. The anesthesiologists have to push it and reduce the beats per minute. Also, with the CBCT, if you remove and you reduce the beats per minute, you can have good images. We will stress our protocols to see about the coronary arteries for the brachycephalic dose that we want to see for pulmonary stenosis. So in the future, we'll have also cardiac protocols. Angiograms, we are sure that we can do it. The way that we approach the contrast duration of the contrast medium is the same that we used it with previous CT scanners. If you have like a 2-slice or 4-slice CT scanner, I started with a 4-slice CT scanner, and the previous one with a big tube and with 0.5 rotation, and it was good. Then I switched to a 16 entry level, and general electric told me that, so 16 slices with a software of 32. I started working. The first month I said, what's happening here? With a 4 slice, I was feeling better because I had a large tube, fast scanning, large detector, 0.5 rotation, so I was very fast and I could scan like for 60 seconds, while with an entry-level CT, the tube is limited. So I have colleagues that have like for Siemens or GE, mostly Siemens because they have the entry level have a small detector and they cannot do studies. They cannot do like the arterial and the venous and the portal phase or the delayed because the tube is overheated. So this is a big limitation if you have a scanner like this. So for the angiograms, what we do is we fix the duration of the contrast injection to the scanning duration. So if you want to see like the abdomen and you have like for example for 30 seconds to scan the whole abdomen, you fix the duration, you can dilute your contrast medium, and you do the scanning with a power injector. That's why it's very important that when you acquire the Vimago, you acquire also the ventilator and the power injector. It could be a single head. We don't need the dual barrel injector. It's only for cardiac, also in human. So don't spend all this money, but a single head is very important. The urinary tract with positive and negative contrast. So we have a lot of lesions in the urinary bladder, ureters, kidneys, and what we can do, for example, we can do exploratory positive studies to see ectopic ureters. What is important and easy for us to help you with a guided, I keep pushing and I keep saying that when you have a Vimago, you should use also the fluoroscopy or the guided. So if you have many times, before the Vimago, I had cases with ectopic ureters that due to an ascending infection, you don't have the excretory phase. You have a ureteritis, you have a pielectasis, and you're waiting like 15 minutes and the contrast medium never gets to the pelvis or to ureter, and you don't see the jet, so you are not sure. And then we were trying to think about doing something with the heavy T2 sequences in MRI. And this takes time. And it's not, if it's a fat dog, it was good. But if you don't have adipose tissue around the ureters, you are not so sure. That's why it's easy to inject the contrast medium directly in the pelvis through guided. It's more safe and it's an easy application. As we said about the exotics, avian and zoo animals, we're working on that and we have very good results. But I will be focused a little bit on the guided brain biopsies, thoracic or abdominal biopsies, tumor ablation, and lymphangiography. I will review a little bit about what is the ablation. We have which type of ablation could have to provide an application in veterinary medicine. So the thermal energy-based tumor ablation. What do? We do cytotoxic effects through hypothermic mechanism to induce tissue necrosis is our goal. Cryoablation impacts tissue through direct cell injury and ice ball formation and coagulative necrosis, vascular injury and ischemia. While the laser ablation, with the laser ablation, we have interstitial thermal therapy that utilizes electromagnetic energy to induce coagulative necrosis through hyperthermic mechanism. My presentation blocked. Macrowave ablation, what we do is under ultrasound or CT image guidance. You have thermal ablation modality that you have transmission of microwaves, electromagnetic energy, through an antenna into the tumor tissue. The radiofrequency ablation, you could have can be monopolar, in which the current is transmitted through an interstitial electrode and returns through grounding pads on the skin, or bipolar, in which the current oscillates between the two interstitial electrodes in the absence of grounding pad. And the high-intensity focused ultrasound ablation, it causes coagulative necrosis of target tissue within the focal plane of the ultrasound beam. So this was a review of the thermal ablation that we now is approved that we can have it in the veterinary medicine. Let's go to the non-thermal energy-based ablation in veterinary medicine. We apply energy to manipulate cellular properties or mechanically disrupt target cell to kill the cell via non-thermal mechanism. The non-thermal tumor ablation may achieve more uniform ablation and be more widely applicable across various tissue types and near critical structures. So let's start with histotrypsy. Employs pulsed high-intensity focused ultrasound waves for the non-thermal destruction of targeted tissues. With the reversible electroporation or the high-frequency irreversible electroporation, what we do, it allows for simpler procedure as does not require the need of neuromuscular blockage or cardiac synchronization and reduces the number of electrodes needed for every treatment. So when we were doing with a neurologist that we were speaking about to do brain biopsies, what was the problem? The problem is that we have a lot of different shape. Brachycephalic, dolichocephalic, mesocephalic dogs, so you cannot have all the types of guidance to do brain biopsies or to navigate. What I was finding crazy, I love surgeons are our friends, but sometimes we call them to do more that there is a field of interest. So I thought that it was crazy because we have an oncological center that collaborates a lot and we have a lot of nasal tumors. And there was the surgeon that coming and they were performing the osteotomy, opening like a trunk, taking out the majority of the neoplasia and then closing. This is very invasive. And why we don't do something easy, applicable? Most of the people, they have TPLO kits, they have endoscopy that they don't use because TPLO thing is very difficult, you have to be very experienced. But most of the vets, they buy it because the distributor go there and there's the TPLO. It costs like $3,000, so you can do it. You have all, but it's not easy. I'm speaking to start working on easy things that they change also the quality, the quality of the patient. So radiofrequency ablation of nasal carcinomas are still reported, but we don't do it commonly. Why? Because we don't feel confident. We should treat our patients. You do a CT scan, you do it in the contrast medium with a VMAG, you can see if you have lysis of the cribriform plate, you can see the parenchyma of the brain. You should be sure you could navigate, be precise, and do your treatment. So this is not only the CT, the problem that we have the CT now, they're getting backwards, not forward. They go to entry levels with small tubes, and they have a plateau of their services that you can do. With the CT, you can scan the dog and that's it. You cannot do further, you cannot do treatment. Stereotactic CT-guided brain biopsy. We try to do it, but why we don't do it? Because we cannot have all the printed models for the shape and the size of the dogs and the cats. That's why we push our team from Imaginalis to work on that and with a navigator to do biopsies. Because it's very important to know which type of neoplasia do you have. There's the comparison of serostatic brain biopsy techniques in dogs, neuronavigation 3D printed guides, neuronavigation with 3D printed guides. It's a recent paper. So as you can see, you can print your guidance and then take samples. This is something that I prefer to do it freehand. So if you have a navigation, you can do your CT scan and you navigate with a system, with a Delphi. You can go precisely, take your samples, and have the result. Because the owners of the pets need more. We are not, this is 2025, we don't need only to say if there's a mass or not. We say which type is, and if we can do something. CT-guided brain biopsy. They're using a modified Pelorus Mark III stereostatic system, and they had done it in 50 dogs. So it's something that is reported, but then we don't apply that. Why? This is 1999. Why we don't do it all these years? Because we don't feel comfortable. Because it's not easy for us. So if you have a navigation system, it will be much more easier. And as you said before, it's very important in our team to feel comfortable with that. That everybody in the clinic should do it safely. Like with cystocentesis or abdominocentesis. When I was a student, I did it blinded. You're grabbing the urinary bladder and you're going blinded with a needle to take urine. But now, it does go without an ultrasound. Nobody. So in a few years, nobody will do a MIELO blinded. They will do it all guided, or samples guided, or treatment guided. Solitary hepatic tumors or abscesses. We do alcohol injections, something very invasive. You have to repeat it a lot of times and sometimes have complications. So why don't we stick a needle, we do cryo or whatever ablation you choose, or it's easy to access and treat the patient. So consider that in one anesthesia, if you have the equipment, you can do like the scanning and the therapy. That's perfect. And our patient will be happy. The future will be also in the zoo, in the aquarium, with specific models. All the people they ask. I have board certified colleagues that are in the zoo, and they wanted a CT and to have a CT in their facilities, and to have also an online connection with radiologists to interpret and find the treatment. And the surgical navigation, as I mentioned, I think is a tool that everybody should have it in the future in order not to help only for the surgeons, but also for the treatment. So consider that this is a tool that you have a lot of options. The important thing is that we should train our team, spend time, and invest on our knowledge. And then you have a lot of possibilities. There's no plateau. What is very interesting, before surgery, lymphangiography, mapping, there are a lot of, my supervisor told me once, like, you have to do the mesenteric injection, and I was pushing to do, like, the mesenteric lymph nodes are movable, so I have to stick the needle there and inject an amount of contrast mean of the popliteal. So if the popliteal lymph node is normal, how you inject? There are a lot of complications. Now, what they published, you can do in the metatarsal pad. It's something easy. We do it commonly. We do it commonly for the helothorax, and the helothorax is like not to find where is the rupture, but in order to say to the surgeon with the mapping at the level of the thoracolumbar junction, if it's like trifurcation, bifurcation, if it's where to go to do the suture. And also, it's very easy for cats. It's crazy to try to find the popliteal lymph node in a normal popliteal lymph node in a cat. You need 18 megahertz transducer, and you have to be very good, but still, you will rupture the lymph node. So with a pad, you do the massage, and then you do the scanning. You can have the mapping. And that's something we can do with the Vimago. So if you have chylothorax, you can do the same procedure that you do with the CT, and you have the mapping of the cisterna chyli and the thoracic duct, while you can do the mapping around, you inject the contrast medium around the mass, and you're waiting to see the drainage, to see the sentinel lymph node. What is the limitation of the sentinel lymph node? And this is, scintigraphy is the best option, because if the sentinel lymph node is full of metastases of neoplastic cells, the contrast medium doesn't go there. So you don't have an uptake. But the lymph node won't be normal. So it will be enlarged, you will lose the ileus of the lymph node. So if the lymph node is abnormal, you should do an FNA or take it out. If it's normal and you want to see an early metastasis, you do the mapping with electrophysiography. Thank you very much.